Lithium is a medication with a narrow therapeutic index. That means there's only a small difference between a safe, effective dose and a dose that's either too low or too high. Due to this, healthcare providers use blood tests to help them find the right lithium dosage for your symptoms. The goal lithium blood level typically ranges between 0.6 mcl and 1.5 mcl, depending on what you're taking it for. What is lithium toxicity? Lithium toxicity occurs when you have too much lithium in your body. A lithium blood level over 1.5 mcl increases your risk for lithium toxicity. But not everyone who experiences lithium toxicity has a high blood level. It can also happen when your blood levels are normal. This is more common in older people or those with kidney disease, but it can happen to anyone. Your healthcare provider will look at both your blood levels and your symptoms to see if lithium toxicity is an issue for you. Lithium toxicity has three main categories. Acute toxicity, acute or sudden. Toxicity typically happens if you take too much lithium in one dose or over a short period of time. Chronic toxicity. Chronic long-term toxicity can happen when lithium slowly builds up in your body over time. Acute-on-chronic toxicity. This happens when you're taking lithium as prescribed, but then have a dose increase or drug interaction that pushes levels too high. Chronic and acute-on-chronic toxicity are considered the most dangerous of the three. That's because with chronic use, lithium has more time to be absorbed into your brain. This can cause more serious side effects at toxic levels. How common is lithium toxicity? Lithium toxicity doesn't seem to be as common as healthcare providers once thought. One study followed 1,340 people taking lithium for 16 years. Based on the data collected, it found that lithium toxicity happens in about 1 out of every 100 people taking lithium each year. Frequent monitoring has also made a difference in managing lithium toxicity before it becomes deadly. A 1978 study reported death in 9% to 25% of people who experienced lithium toxicity, but in 2012, the U.S. death rate from lithium toxicity was only 0.16%. Lithium has multiple levels of action, from macroscopic to microscopic levels. We'll discuss some abnormalities found in the brain structure of bipolar patients and changes in brain structure linked to lithium therapy. Then, we'll study how lithium modulates dopaminergic, glutamatergic, and GABAergic neurotransmission. Finally, we'll explore intracellular changes associated with lithium use. Lithium has shown neuroprotective effects in a number of brain regions. This has been suggested by changes in gray matter volume. We can see regions that have shown improvement after lithium treatment. The regions are the cingulate cortex, superior temporal gyrus, and ventral prefrontal cortex. Other regions involved include the hippocampus, paralimbic association cortex, and left amygdala. Let's continue now with the effects of lithium at the neurotransmission level. It inhibits excitatory neurotransmitters such as dopamine and glutamate and promotes GABA-mediated neurotransmission. There is a hypothesis called the cyclical dysregulation hypothesis. This theory postulates that during mania, dopamine neurotransmission is increased. This elevated state would cause downregulation of dopamine receptors. A consequence of downregulation would be decreased dopaminergic neurotransmission associated with clinical depression. Postsynaptic activation of dopamine receptors is mediated by G-protein-coupled receptors or GPCR. Chronic administration of lithium can alter the functionality of GPCR subunits. Because of this, dopaminergic neurotransmission is inhibited. Lithium induces downregulation of NMDA receptors. As a reminder, the NMDA receptor is a subtype of glutamate receptor. Glutamate is an excitatory neurotransmitter that is elevated during mania. Lithium acutely stimulates the NMDA receptor, increasing glutamate availability in the postsynaptic neuron. After chronic administration, lithium induces NMDA downregulation. This way, lithium modulates glutamate neurotransmission. Now we can see the effect of lithium on GABAergic neurotransmission. GABA is an inhibitory neurotransmitter that modulates dopamine and glutamate neurotransmission. Research shows that in bipolar patients, GABAergic neurotransmission is reduced. Lithium increases GABA levels in cerebrospinal fluid. At the presynaptic level, lithium facilitates GABA release. At the postsynaptic level, it upregulates GABA-B receptors. Now we are going to discuss at intracellular level. First, inositol, a carboxylic sugar, is converted into phosphoinositol by adding a phosphate group. Phosphoinositol is then converted to phosphoinositol 4-phosphate by adding another phosphate group. Then, a third phosphate group is added to form phosphoinositol 4,5-bisphosphate. Then, a membrane-bound enzyme called phospholipase C splits phosphoinositol 4,5-bisphosphate into diacylglycerol, or DAG, and inositol triphosphate, or IP3. IP3 increases the intracellular calcium levels, which triggers the release of neurotransmitters to the synaptic cleft. However, IP3 should be converted back to inositol before it can be used again. IP3 is dephosphorylated to form IP2 and then into IP1 by an enzyme called inositol phosphate phosphatase, and ultimately into inositol by the enzyme inositol monophosphatase. It is postulated that lithium inhibits these enzymes and prevents the recycling of inositol, which will lead to decreased neurotransmitter release. What causes lithium toxicity? There are two main ways lithium toxicity happens. Either too much lithium is entering the body or not enough lithium is leaving the body. Too much lithium entering the body can happen if your dose is too high. It can also happen if you intentionally or accidentally take too much lithium. Lithium is removed from your body by the kidneys, so anything that affects your kidney function or that makes you pee less can raise your lithium levels higher than they should be. This includes dehydration caused by vomiting, diarrhea, a fever, or not drinking enough water, heart failure, intense exercise, or heat exposure, especially without proper hydration, suddenly lowering your salt intake, and kidney disease. Other medications can also raise lithium levels if they're taken together. This can increase your risk of lithium toxicity. Some common interacting medications include non-steroidal anti-inflammatory drugs, NSAIDs, such as ibuprofen, Motrin, and naproxen, Aleve, ACE inhibitors such as lisinopril, Zestril, or enalapril, Vasitec, thiazide diuretics such as hydrochlorothiazide, Microzide, loop diuretics such as furosemide, Lasix, and calcium channel blockers such as diltiazem, Cardizem. Signs and symptoms of lithium toxicity. The symptoms of lithium toxicity depend on how severe it is. Mild lithium toxicity, which is 1.5 to 2.5 milliequivalents per liter, includes symptoms like nausea or vomiting, fatigue, and diarrhea. You may also notice a small tremor in your hands and feel lightheaded. These symptoms are also common lithium side effects. So if you experience them, it's best to contact your healthcare provider to get your blood level checked. They can help determine if your symptoms are a sign your lithium levels are too high. Moderate lithium toxicity, which is 2.5 to 3.5 milliequivalents per liter, includes symptoms like confusion, agitation, and a rapid heartbeat. You may also notice slurred speech, blurry vision, and a worsening tremor. Severe lithium toxicity, which is greater than 3.5 milliequivalents per liter, includes symptoms like uncontrolled muscle movements, seizures, and trouble breathing. You can also have abnormal heart rhythms and other toxic effects on the heart. If untreated, this could lead to coma and even death. Acute lithium toxicity usually causes more gastrointestinal side effects. Chronic lithium toxicity is more associated with the effects on the brain and nervous system. This is why chronic lithium toxicity can be more dangerous. If you think you might be experiencing lithium toxicity, contact your healthcare provider. Now, what are the symptoms of acute and acute-on-chronic lithium toxicity? Early symptoms of acute lithium toxicity include gastrointestinal problems like nausea and vomiting, diarrhea, abdominal pain, bloated stomach. These symptoms usually develop within 1 hour of taking excess lithium. If you have moderate to severe lithium toxicity, you'll likely get neurological symptoms after the gastrointestinal symptoms. These include mental status changes that can range from mild confusion to delirium, uncontrolled shaking known as tremors, coordination and balance issues also called ataxia, muscle twitches or myoclonus, slurred speech which is dysarthria, overactive reflex responses known as hyperreflexia, uncontrolled eye movements called nystagmus, hyperthermia in severe cases, seizures in severe cases, coma in severe cases. Get immediate medical help if you take lithium and have these symptoms. Symptoms of chronic lithium toxicity. People who have chronic lithium toxicity often develop kidney damage. It's connected with certain kidney diseases that have different symptoms. Nephrogenic diabetes insipidus happens when your kidneys can't properly balance bodily fluids. Your body can't respond properly to a natural hormone called antidiuretic hormone. Its symptoms include dehydration, including dry mouth, fatigue, and dizziness. Excessive thirst, known as polydipsia, large amounts of urine output or polyuria. Sodium-losing nephritis happens when kidney damage leads to electrolyte imbalances. Symptoms include muscle cramps or weakness, mental status changes, fatigue, excessive thirst, polyuria. Nephrotic syndrome happens when your kidneys release an excessive amount of protein known as proteinuria in your pee. Symptoms include high cholesterol, also called hyperlipidemia, swelling or edema in your legs and feet, loss of appetite, abdominal pain, foamy pee. Chronic lithium toxicity can also cause endocrine system issues, including hypothyroidism, hyperthyroidism, hyperparathyroidism. Talk to your healthcare provider as soon as possible if you develop any of these symptoms while taking lithium. Lithium and serotonin syndrome. Lithium can induce serotonin syndrome, especially if you take other medications that affect your serotonin levels. This is another potentially life-threatening condition. Symptoms of serotonin syndrome, from mild to severe, include nervousness, nausea and vomiting, diarrhea, dilated pupils, tremor, agitation, restlessness, muscle twitching and muscle rigidity, sweating and shivering, confusion, disorientation or delirium, rapid heart rate, and high blood pressure. Get immediate medical help if you have these symptoms. What are the risk factors for lithium toxicity? Risk factors for chronic lithium toxicity include being over 50, thyroid disease, impaired kidney function, and diabetes insipidus. Long-term lithium use also increases your risk of lithium-induced nephrogenic diabetes insipidus, which can then lead to lithium toxicity. Talk to your healthcare provider if you develop any of these conditions while taking lithium. Diagnosis and tests. How is lithium toxicity diagnosed? To determine the severity of lithium toxicity, it's very helpful for healthcare providers to know how much lithium you took, what time you took it, whether you took other medications or substances with it, and if the ingestion was intentional or accidental. To diagnose lithium toxicity, providers order several tests, including blood tests to measure your lithium levels, blood tests to measure your electrolytes like sodium and calcium, blood tests to measure your thyroid-stimulating hormone, TSH levels, urinalysis, kidney function tests like blood urea nitrogen and creatinine, and brain imaging tests, although this is rare. They'll also monitor certain aspects of your health like your heart with an EKG, electrocardiogram, how much you're peeing, urine output, and your oxygen levels, likely with a pulse oximeter, pulse ox. Supportive care. Attention to correcting any water or sodium deficits are required to maximize lithium excretion. In an acute overdose, aiming for more than 1 milliliter per kilogram per hour of urine output is recommended. Cease any drug that may impair renal function. Decontamination-activated charcoal does not effectively absorb lithium. Enhanced elimination lithium can be eliminated via hemodialysis, but it is reserved for patients with established renal impairment or those with clinical features of neurotoxicity. For all other patients, forced diuresis as described in supportive care is normally sufficient to avoid neurotoxicity. It should be considered in anyone with neurological dysfunction and a lithium level greater than 2.5 millimoles per liter. Prolonged and repeated hemodialysis sessions may be required, as it takes a long time for the lithium to redistribute out of the CNS and the concentration gradient needs to be maintained. Antidote, none available. Disposition. Acute ingestion patients with no evidence of neurotoxicity and a serum lithium level less than 2.5 millimoles per liter and falling can be medically cleared. Chronic poisoning always require admission. Resolution of neurotoxicity may take weeks to resolve and occasionally may be incomplete.